Hey everyone, and welcome to this explainer. Today, we are firmly putting on our medical detective hats for a pretty fascinating journey into reproductive psychiatry. We're going to explore how our biological timelines essentially crash right into our mental health. And specifically, we're mapping out the step-by-step clinical framework for diagnosing and managing these incredibly complex conditions.
Okay, let's dive into this. It's a question that basically sits at the very heart of reproductive medicine. The human body undergoes just massive biological shifts during the reproductive cycle, pregnancy, and postpartum. But how do clinicians actually separate typical biology, the standard ups and downs of hormones, from a diagnosable clinical pathology that requires urgent intervention? That separation, how doctors actually make that call in the real world, is exactly what we're going to unpack today.
Section 1, Spotting Menstrual Cycle Disorders. Let's get into it.
So, if you're thinking like a clinician, you can't just look at isolated symptoms, right? You really have to look for a highly specific pattern. A doctor will suspect a clinical issue when they see chronic, cyclical, physical, and emotional symptoms appearing specifically in the luteal phase, which, if you remember, is the second half of the menstrual cycle. It's that precise cyclical timing that gives the clinician their first major clue.
Now let's look at how we classify severity. Premenstrual syndrome, or PMS, affects roughly 20 to 30% of women, bringing about fatigue, irritability, and physical cramping. But compare that to premenstrual dysphoric disorder, or PMDD, which affects a much smaller 3 to 8%. The clinical differentiator here, markedly depressed mood, severe anxiety, and intense affective lability, meaning wild, completely unpredictable mood swings. And the true clincher for PMDD, these severe symptoms absolutely must vanish within a few days of menses starting and remain completely absent the week following. But here is where the clinical detective work really kicks into high gear. Before a doctor can confidently stamp a PMDD diagnosis on a chart, they've got to rule out a massive list of differentials. We're talking underlying depressive or anxiety disorders, migraines, chronic fatigue syndrome, irritable bowel syndrome, and hypothyroidism, all of which can suddenly flare up just prior to a cycle. Gynecological issues like PCOS or endometriosis must also be carefully excluded. You see, you just can't effectively manage PMDD if the root cause is actually an underlying nutritional deficiency or a thyroid issue. All right, so once diagnosed, how do we actually manage it? Well, doctors use a very clear escalation scale. Step 1 is conservative. Lifestyle modifications like a low salt, fat, caffeine, and sugar diet, combined with aerobic exercise. If that fails, step 2 introduces targeted psychotropics. Interestingly, medications like SSRIs, such as fluoxetine or alprazolam, are oftentimes specifically to the luteal phase, so they start 2 weeks prior to the cycle and stop when it begins. Step 3 is for those tough, therapy-resistant cases, ranging from diuretics for edema to oral contraceptives or, as an absolute last resort, surgical options like a bilateral oophorectomy. Moving right along to Section 2, Pregnancy Psychiatric Risk Factors. So the crucial point is, the baseline incidence of mental illness does not actually rise during pregnancy. Experiencing symptoms of anxiety and depression during this time is, biologically speaking, entirely normal. It's incredibly important that we normalize these symptoms to relieve the heavy stigma many expectant mothers feel. The pregnancy itself doesn't just spontaneously generate mental illness at a higher rate than the general population baseline. However, clinicians are always on the lookout for specific red flags that identify patients at a legitimately higher risk of developing a psychiatric condition. A family or personal history of depression is a major indicator. Doctors also carefully screen for ambivalence about the pregnancy, high baseline levels of neuroticism, and a lack of social supports. Catching these early, that's the absolute cornerstone of proactive management. Now, while assessing pregnancy, doctors occasionally encounter truly astonishing presentations, like pseudokinesis. This is a somatoform disorder, essentially an incredibly powerful mind-body connection, where a woman firmly believes she is pregnant, and, amazingly, her body actually develops objective pregnancy signs, all in the complete absence of a fetus. To manage this safely, doctors must rapidly rule out dangerous medical mimics like ectopic pregnancies, pelvic tumors, or luteal cysts. Once cleared, the management pathway shifts entirely to insight-oriented psychotherapy and potentially a trial of antidepressants. It's also vital to monitor mental health outcomes surrounding the termination or loss of a pregnancy. Clinical data indicates that 50%, fully half, of women experience an adjustment disorder or a grief reaction accompanied by depressive symptoms following an abortion. This makes follow-up care a truly critical component of reproductive management.
Which brings us to Section 3, Diagnosing Postpartum Mood Shifts.
Let's move to the postnatal period and see how this builds. Because across the intense chronological timeline following birth, specific biological drops trigger very specific clinical disorders. Right around 72 hours postpartum, there is a massive drop in estrogen, progesterone, and prolactin. Right on the heels of that, at 2 to 3 days, we see the onset of the baby blues. Pushing out to 2 weeks hits the peak occurrence window for postpartum psychosis. And pushing further, to 3 to 4 weeks postpartum, we see the peak onset of postnatal depression. For a clinician, timing is absolutely everything here.
Looking closer at those early weeks, we really have to distinguish between the baby blues and postnatal depression, or PND. The baby blues affect up to 75% of new mothers. It's marked by short-lived tearfulness and emotional lability, and crucially, management simply requires reassurance and observation. PND, however, hits 10 to 15% of women. It is a severe depressive episode where the thought content often features intense, debilitating worries about their ability to cope or the baby's overall health. And finally, Section 4, Managing Severe Childbirth Disorders.
Postpartum psychosis is exactly that, an absolute severe psychiatric emergency. It is an acute psychotic episode occurring in roughly 1.5 out of every 1,000 live births. The clinical markers include rapid lability, profound insomnia, total bewilderment, and, terrifyingly, thoughts of suicide or infanticide. This condition requires immediate identification of at-risk individuals long before these symptoms ever peak.
Now, what's really interesting about this slide is you might assume this psychosis primarily mimics classic schizophrenia, right? But in the real world, a massive 80% of postpartum psychosis cases actually present with prominent affective symptoms, meaning severe mania or severe depression accompanied by psychotic features. Only 15% present as a schizophreniform disorder resembling typical schizophrenia, and 5% as an acute organic psychosis. Knowing exactly what to look for visually and behaviorally completely dictates the immediate treatment.
Because it is a life-threatening emergency, the treatment protocol is highly structured and incredibly aggressive. Hospital admission is essentially mandatory across the board to ensure everyone's safety. From there, the medical playbook diverges based on those symptoms we just tracked. If it's a major affective disorder, the evidence strongly points to electroconvulsive therapy, or ECT, along with mood stabilizers like carbamazepine and early antidepressants. But if schizophreniform psychotic symptoms are the primary driver, management leans heavily into targeted antipsychotics.
To wrap things up, the data shows us that postnatal depression persists for a year or more in 25% of cases. When you step back and look at how clearly defined these diagnostic windows and management protocols actually are, from luteal phase lifestyle tweaks right up to emergency hospital admissions, you really have to ask, how many lives and entire families could be dramatically changed if both patients and providers universally understood and applied this clinical roadmap?